I work 3 days a week as the Workforce Development Lead with Nottingham City GP Alliance. So I support, particularly with mentorship and supervision, a team of about 55 pharmacists and pharmacy technicians across Nottingham City. I also spend 1 day a week working with NOT's Training Hub, where I support with the multi-professional support unit. So delivering sessions for all the primary care teams. I hope you may have come across me in one of those sessions there. I am a non-medical prescriber, so I do prescribe. My specialist areas are COPD, asthma. I also dabble in hypertension and lipid prescribing. So yeah, that's where I come from. And I've had a background of working in the NHS through lots of different sectors. So I've worked as a community pharmacist, a hospital pharmacist, and I've been in primary care since 2015. So that's me. But I know AHPs cover a whole range of roles, and some prescribe and some don't, which made writing this presentation a little bit tricky. So I was wondering if you could put in the chat who you are, if you've not done that already, and to be really helpful for me, what your role is, and if you're a role that does prescribe, that you do that, just because then I can add and change bits and flex the talk a little bit to you, to hopefully mean that you take away something new. So I'm just going to put up the chat. So we've got a dietitian, and welcome Emily, non-medical prescriber student about to finish, or FCP physios. We've got a lot of physio, more dietitians. First Contact Physio, we've got another prescriber. We've got a mixture there of prescribers or not. Oh, nurse and GP currently awaiting exam results. Nurse practitioner not currently prescribing, hoping to do course soon. Brilliant. So we've got a bit of a range, so I will try and bear that in mind. First Contact Physio. Nimra, do you prescribe? Cool. Pale, I do cover a bit of that. No, thank you. So I might cover a little bit more about contraindications and indications and things like that. Right, let's make a start. Now, I did try and get the chart music for the top 10 drugs, but I failed miserably on doing that. So if at some point I break into singing, then I apologise in advance. So the agenda or learning outcomes for today is, after this session, you're expected to be aware of the top 11 medicines prescribed across the Nottinghamshire. The reason I've chosen 11 is I really like the 11th drug. And there are 2 medicines in the top 10 that were very, very similar. So I thought I would make it 11. So I apologise, it's the top 11 medicines. And you all have different roles. You may interact with medicines in different ways. So it was quite hard to write specific learning outcomes for that. So I was going to put a general one. So I'm hoping that there are some takeaways from this session so that you can go away and reflect on how some of the knowledge you gain from today may be relevant to your practice. So we're going to start with number 11. So da 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 da. Oh, actually, before I go, I just want you to put in chat to see how many people get it right. What medicine do you think is the most, so the number one? You'll have to wait the whole presentation to get there. But in chat, what medicine is prescribed the most in Nottinghamshire as per a month ago? But I suspect it's still valid. So, and then we can, I don't have any official prizes, but you can have a pat on the back. So we're having a go. That's quite broad, going for painkillers. Is that pain, PPI? amoxicillin, cocodamol, paracetamol, naproxen. I'm not going to tell you. I'll just give you a moment more to put in a few guesses. I can tell you now that at least one of you have got it right, and that some of the other ones are definitely in the top 11. Okay, brilliant. So there may be some pats on the back for certain individuals later had they got it right. Okay, so at number 11, it is salbutamol. Does that surprise anyone, or did you think it should be more or less? So this is a commonly prescribed medicine, it's top 11. It's a beta agonist inhaler, and we will see it used in respiratory conditions, notably asthma and COPD. It's important as a clinician that you're aware of the indication, because actually, depending on whether they're asthma and COPD, could trigger what interventions you make and things like that. With regards to side effects to be aware of, it can make patients feel a bit shaky, give them headaches, and it make them aware of their heartbeat and kind of muscle cramps and things. It's more likely to occur if they're a bit of a blue puffer, things like that. But sometimes you'll notice if you're reviewing patients who've taken quite a bit of salbutamol before their reviews, that they're sitting there shaking and their hands are tremoring ever so slightly. So to just be aware of that. It can also cause hypokalemia, so that's low potassium. In primary care, it's unlikely for that to be a particular issue. But potentially if you're managing someone on salbutamol nebs, or they're on some other medicines that might lower their potassium, that might become more prevalent. So just have that kind of awareness of that. So as I said, this is an interactive session. So we're going to start with a case study. So we've got Mrs. Singh attends your clinic as arranged. She has a history of asthma. At the end of the clinic, she asks you for an extra salbutamol inhaler. So you've done, because I was trying to make sure that I prepared for many, many roles. Well, I don't know if someone's got their microphone on. There's a bit of background noise. If you could make sure that you're on mute, that would be amazing. She asked you for an extra salbutamol. So what would you do? I don't know if someone wants to unmute and talk about what they would do. If someone does,
I would like to ensure that if they are using the correct dosage for salbutamol, because there is a risk that a patient might try to use more puff to get their symptoms ease, and there is some evidence around it that they might use a bit more puff. So it's important to know how they've been using in the past and what's their understanding.
Cool. So finding out a bit more about why they're asking for it, finding out how many they've had. Brilliant. And would you arrange for a salbutamol to be issued? Would anyone do anything differently or add in anything to that? Feel free to write in chat if you, okay, so when was the last long-term condition review? Is it a spare one or is she overusing? Checking dose compliance? Yeah, it would very much depend on the answer you get. So how many if you're an asthmatic, if you're a normal asthmatic, how many salbutamols should a patient be requesting within a year? Julia, yeah, you're right. You want a bit more information, but it's within your competence, and this would be where you might need to signpost, but having a bit of an awareness would be quite useful. So how many, you can put this in chat or someone can unmute, how many salbutamols should someone be having in a year maximum for an asthmatic? And this is why it's really important to know the difference between asthmatic and COPD. So Nicola's gone for 2. Anyone going to say anything different? There was a big hint on the slide. I thought I'd hidden that, but not done a very good job. 1, yeah. 1 to 2. So good answers there. So as a general rule, because asthma is an inflammatory condition that we can treat generally in the majority of cases when it's not severe or brittle with inhaled corticosteroids and montelukast and things. And if we've treated it correctly, we shouldn't really be using the salbutamols very much because they only treat the symptoms. So if we go to the next slide, I don't know if people want to put their hands up. How many people have come across, it's quite old now, but still actually is relevant to practice, the National Review of Asthma Deaths. So I will send these slides out afterwards and it'll have all the links that you can use. Has anyone come across you can just raise your hand and we'll put it down. So in 2014, they reviewed everyone that died from an asthma attack, and they realised that 43% hadn't had an asthma review, 45% died without seeking medical advice, 39% had been prescribed 12 or more SABAs, and 23% of patients had an action plan. So there were loads that didn't have an action plan. So it's important if you're seeing these patients and they're ordering lots of salbutamol that you're checking they've had a review, you're signposting to members of the team that can do reviews, checking they've got an action plan. If they don't, that might be where you need to do additional safety netting to make sure they know what to do if their breathing worsens. And yeah, just making sure they seek that medical advice. Because there's sometimes a little bit of hesitation to do that. And it's easier if they're having to use their blue one more often. That is a good point to get them on their journey into a review before they're at where their breathing is so bad that we're sending them into hospital. So it's just having that awareness that lots of blue inhaler use in asthmatics could be a sign that their asthma is not under control and that they need an action plan, they need a review and things like that. It is different if they've got chronic obstructive pulmonary disease because that condition is not reversible. It's a group of conditions where damage has happened to the lungs and they will need salbutamol more regularly. So we need to make sure that we distinguish between the two conditions. So we do have a couple of complaints and incidents raised by patients that they can't get their salbutamol. They've been refused it because they're ordering it too often, but actually they have COPD and it is appropriate potentially in their cases. Again, they still need their long-term condition reviews and they need things optimized so that they're using as little salbutamol as possible, but they're in a slightly different case. There is an encouragement for everyone to have a kind of a foundation level of asthma care, and e-learning for health have really good e-learning modules to give that awareness. So not necessarily, depending on your role, we're not expecting you to manage these asthma patients, but just be aware of signposting and highlighting patients that might have uncontrolled asthma. Do we have any questions about that? No. Right, I will move on to number. Oh, Pale. If we go to 10, what's your question?
I have one question about the side effect. That's the muscle cramp, you said.
Yes.
We have to check for that side effect. So basically, because sometimes we are physios and patients are coming with muscle pain or muscle cramps to us, so we have to check for that side effect after starting new dosage, or it could happen after if they are on that for years as well.
Potentially, I think it can happen. It's got quite a short half-life and it's amount dependent. So if a patient's only using it once or twice a day, it's really unlikely, I think, for it to be the cause. But if there's someone that is using a lot, which you do get with the severe end of the spectrums of COPD and asthma, then it might need to rule it out. But I mean, I've never encountered that particularly in practice. I can look into it a bit more. I've definitely seen the shakes, and definitely you can feel your heartbeat. But I suppose keep it as a differential, but if it suddenly has come and they haven't recently taken much blue inhaler, so it's getting that history of where the muscle cramps are happening, and if it's not associated with, because salbutamol use is a bit ad hoc and irregular, so you can get that picture and then match it up with the muscle cramps, and if it's associated, then it definitely could be a differential. But if they're getting muscle cramps and they haven't taken their blue inhaler for days, it's unlikely to be that, if that makes sense. I've got another question.
Yeah, thank you. I think it's not a question, it's what my experience is. I think any cramp which is related to the medication or drug, it's more within the half-life, and second, it is very reversible and transient kind of thing. Any muscular cramp is a bit more long-lasting and there's a mechanical pattern behind it. So it is susceptible for cramps, but what I feel with salbutamol, or what I've seen, it's more shaking of the hands, or in some cases, that's beyond our scope of routine practices, the arrhythmias. So beta agonists can cause arrhythmia. So that's two things which I've seen more frequent.
You get that feeling of sensing your heart beating. I say that from being a patient perspective as well. Having had salbutamol nerves, you feel it, you become really conscious of it. So yeah, you'd need a good history would be the way of distinguishing it. Thanks for that. Right, number 10 is metformin. So this is going to be completely, all these medicines are often quite unrelated to each other. So it's definitely a flying around here. So metformin is an anti-diabetic biguanide, and it's got a multi-factor method of working. So it reduces the glucose production in the liver, it increases insulin receptors in the muscles, so it takes up more, and then it delays the absorption of the glucose in the intestine. It is believed to have cardiovascular benefits, and is weight neutral, and hence it's really popular and first line in NICE guidelines and things like that. Its side effects, the main one that you would see is nausea, diarrhea, and abdo pains, and particularly if not slowly titrated. So with metformin, we normally go slow. So you start with 1 tablet for a week, 1 tablet twice a day for a week, and then slowly increase it. You can still get GI disturbances and effects, in which cases we would swap to the modified release. So we can still use it, but use a slower version, and that generally is well tolerated. It's generally one of our preferred options because of the weight neutral aspect and the cardiovascular benefits. The other ones that also have similar benefits are the SGLT2s that are becoming increasingly popular. And there's some change in guidelines going towards them being first line in some cases as well. But at the moment, NICE says metformin. So some of you are already prescribers and might have knowledge of this very common medicine. So I can see a lot of you on the screen. So you can either use the react button that's on the top of Teams, or you can give thumbs up and down. So this is testing your knowledge. It does not matter if metformin is taken with or without food. This is the first question. What do you reckon? Thumbs up, true, or thumbs down, false? I can't see any hands at the moment. Is that statement true or false? Are you sat on the... What's that? That's cheating. So anyone put anything in the chat? True or false? True. Oh, I like your honesty. So the answer is false. We normally recommend that it's taken with food. And that's because here it delays the absorption of glucose in the intestine and things. So we want it taken at the same time. Laura's got it right. She's showing up there. Right, next question. Metformin can cause lactic acidosis. So lactic acidosis. Is that true or false? I'm going to have a look in the chat again. Anyone going to have a go? True or false? True or false? True. Hey, you are correct. It can cause lactic acidosis. And that is why we should be following the sick day rules. Has everyone come across the sick day rules or SADMANs? I've got some nods of the head there. Yes. So metformin is the M in SADMANs. And these are medicines that should be stopped if the patient is likely to be dehydrated. So they're not taking enough fluids because they've got a temperature, viral infection, vomiting, diarrhea, and things like that. So yeah, just be aware that this metformin falls into that. Right, next true or false question. Metformin MR should always be given twice daily. So this is the modified MR, modified release. So this is slow acting. True or false? Mohammed says depends. I like true. Jane's gone for true. This is safe. You can... Depends, not sure. False. Ali, do you want to unmute? Why false?
I think it initially it started as twice a day and then can be increased to 3 times a day depending upon the requirement. Okay,
so because it's slow release, you can actually give the modified release once a day. Because it's long acting and stays long in the body. Sometimes it's given twice a day because a patient prefers to take it that way. The normal release medicines are normally twice a day, although you sometimes see 3 times a day with meals. But yeah, normally normal metformin is twice a day and modified release is once a day, but you do sometimes see it twice a day. So just to bear that in mind. Mohammed, I dread hyperglycemia with my diabetic control medicines. Yeah, that's true. Right, last one. Metformin can reduce B12 levels.
Yes, I certainly know that.
Yes, it is true. So if you've got someone presenting with potential symptoms of B12 deficiency, then consider metformin may be the cause. So just to kind of bear that in mind as a, it was hot off the press on Twitter. I'm not a Twitter person. So yeah, so just bear in mind if they're on metformin and their B12 levels are low, or you're considering that as a differential for the patient that's presenting in front of you, then yeah, metformin could be the cause. So that is that one. Any questions about metformin? But yeah, some practices monitor B12 as routine, some don't. It's one of those ones where they'll check it if they've got symptoms. So it might be worth just checking with your practice. It's not necessarily routinely checked. Right. At number 9, it's sertraline. So that's an antidepressant, one of the SSRIs. and it's used to treat multiple mental health conditions. So we've got depression, we've got anxiety, we've got panic, we've got OCD, it's got an indication for loads, which is why it is the only SSRI in this top 10. I suspect you've all been familiar with it. Significant side effects is it makes you feel sleepy, dizzy or weak, and it's just making sure that the patient's aware in those cases to not drive or operate heavy machinery. It can cause mood changes, such as feeling anxious, nervous or agitated, particularly when that patient first starts taking. So in case you see this patient early on, it might be that you just need to reassure the patient that it could be because they've started on sertraline and it normally settles within a few days. However, there still is a risk of suicide, so you might need to make sure you're safety netting for that. And that risk is particularly high in children, adolescents and young adults. I've put the grapefruit warning there because this is a medicine where we recommend that they don't drink loads of grapefruit juice with it because of the interactions there. I think I've gotten some important considerations. So as a clinician, it's important to understand there's a time delay. So it can take 1 to 2 weeks to feel any effects, and actually it can take 4 to 6 weeks to see the full benefits. So it might be that patient's making contact with you on their journey, and it might be you need to give them a bit of reassurance. Has anyone come across the choice of medication leaflets? There are links from the NOTS APC website, but there's normally a longer version and a more simple one-page version. So one of your takeaways today might be to go and look at that website and have a look at the information, but I would find them really useful for the patient. And who's come across serotonin syndrome or heard of it?
Yeah, so what I understand from this is that if you try to give 2 or more SSRIs for the medications who work at the same receptors, they can go into this jerky movements, sweating, shakiness, and their heartbeat might have tachycardia. So I've seen a couple of patients, and it's something which is very serious. And the good thing about it is reversible, but it can be very severe.
Yeah. So it's important as clinicians that we have awareness of serotonin syndrome because it could be life-threatening and we need to catch it early because, as Mohammed says, it's easily reversible by stopping the medicine. So it's important that we safety net for it and that we're aware of what to look out for. So as Mohammed said, stiff muscles, fast heartbeat, high temperature, feeling sick or being sick, diarrhea, and feeling delirious or seeing visions. It happens when the serotonin levels get too high, and that's often because they're on 2 or more medicines. We do still use 2 or more medicines that can affect the serotonin receptor. So we still use them, and actually commonly in a lot of cases. So we often use tramadol and an SSRI together, but in which case it's just making the patient aware of what to look out for. It's rare, but it just means we need the patient. Oh, brilliant. So you've seen in primary practice. So that's not brilliant, but at least you've seen it and recognized that it can still happen. So it's having that awareness. So if you're a prescriber, it might be used tramadol short term as a painkiller. So we still see that in practice with an SSRI, but it's important that we safety net the patient to come and seek medical advice if they're getting those kind of side effects. The other one that you might prescribe is triptans for migraines. Again, we still use them, but it carries that risk and we should be safety netting the patient to come back. So yeah, I wonder if patients should be given patient information leaflet. Do you know what? I normally consent, but I quite often send patient.info or nhs.net leaflets on text message with any prescriptions that I've issued, because I like the way they've written, because they often just list the significant side effects and the serious side effects. and what to practically do, whereas the patient information leaflet lists everything and it's really overwhelming as a patient. So I will often send them an alternate evidence-based leaflet that I think is good. Again, if you're counselling on serotonin syndrome specifically, the Choice of Medication website have a really useful leaflet on that, and it's particularly good coverage on the triptans should you be involved in prescribing that. So any questions on sertraline? Just conscious that actually we're already quite significant through our time. So at number 8, we've got Bisoprolol. So that's a cardioselective beta blocker that we see in a lot of patients for heart failure, angina, or post having a heart attack. Occasionally, you might historically see it for high blood pressure, but that's less and less. So significant side effects that you see them is feeling dizzy, sleepy, or tired because it's lowering your blood pressure. It can slow that heartbeat. So sometimes if you've got a patient presenting, they might have a blood pressure of less than 50, in which cases they might need their beta blocker reducing. Cold fingers and toes I've seen reported, disturbed sleep, and one of the side effects that I think is more common but underreported is impotence, particularly in men. So they're not, you don't have those conversations, but I have seen it happening. How might you encounter Bisoprolol in practice? Has anyone come across it? So yeah, beta blocker, not friendly medicine, at least for MSK injectors. Okay. Anyone else encountered it in any form? So yeah, someone might have a lower blood pressure, a lower heart rate if you were checking them over because of the beta blocker. Can you give beta blockers in an asthmatic? I've got some shakes of the heads. So no. So this is not quite true. So non-selective beta blockers, so that includes propranolol, are contraindicated according to the SPC in asthmatics because you're giving a beta blocker to patients that need beta agonists to open the airways. So in asthmatics, we generally don't advise non-selective beta blockers. Bisoprolol is more specific to the beta receptors in the heart, and so it can still be given, but it's a caution. So normally it's started in hospital or somewhere under where they're monitored a bit more closely and checked that their airways aren't narrowing or it's affecting their breathing. So you do see it in asthmatics, but that does not necessarily apply to all beta blockers. So it's knowing your beta blockers and which ones are okay. And propranolol is generally not okay in asthmatics, although it still sometimes gets used for anxiety. So I think I needed a short slide on Bisoprolol. Any questions on that one? No? So at number 7, we had this. Now this one was my most surprising one. So Cholecalciferol was at number 7. So, which surprised me. And whilst it's really important for bone health and recommended by Public Health England that everyone should take a daily supplement, particularly during the autumn and winter months, it should be something where most patients should be buying over the counter. And we normally recommend the 1,000 units because actually those are the strengths that can be purchased from the supermarkets that are good value. There are some patients that we can prescribe, so if they've been given the treatment dose or they've got a medically diagnosed deficiency where they're going to get low levels, with the exception of bariatric patients who should still be buying their own multivitamins. So If they've got a history of osteoporosis and osteopenia, we can prescribe. Often that's in combination with calcium tablets. We can still prescribe for those with malnutrition risks, including alcoholism, and for those normally on a vitamin D analog, so they're the renal impairment patients on alpha calcidol, again, we can prescribe. But this really, really surprised me that it was so high up. There is a really useful self-care leaflet from NOTS APC. The link is there. So if you've got a patient, we should be encouraging them to buy it over the counter. Does this one surprise anyone else?
You know, quite expected.
Sorry.
So yeah, it surprised Alison.
I guess if most people are considered vitamin D deficient, then like commonly prescribed, but yeah, meant to be over the counter, isn't it?
Yeah, it's interesting. Naomi's put about care home residents that are on it, and actually care homes is some really interesting situation. If you look at the statement from the ICB, care home patients should also still be buying it over the counter. So they should have their money in, and the care home should be facilitating them. But practically, that is quite tricky, I think, in the care home environment. But yeah, the statement is care home patients should be buying it over the counter too, unless they fulfill one of these risk criteria. Also depends on the level of vitamin D. Haseeb, do you want to expand on that? If you require a treatment,
yeah, sometimes the GPs would like to prescribe vitamin D in patients with very low vitamin D level in their blood. So they would just give them a dose of vitamin D one time maybe, and then ask them to use the over-the-counter ones.
Yeah, so we often like load them at higher doses, and then encourage the patient, yes,
That's right,
to buy a maintenance dose. Normally we should be, if we load them on a higher dose, we should be checking their calcium levels after they've completed that loading dose, and I don't think that's often done in practice, because sometimes it can mask, I think it's hyperparathyroidism. So yeah, but as I've reported, when the new guidelines were released recently, I'm like, it doesn't happen in practice. They just do the maintenance, they do the treatment course, and they go on to their over the counter. So I don't know what the risks are, but yeah, have a little look at the local guideline if you're involved at all in this area. Right, I'm going to move on. Oh, Mohammed.
Yeah, sorry, I have two interesting facts around it.
Ooh,
so one is that it's always advisable to take it with something which has fatty acids in it or fats in it. So its absorption is highly facilitated if you take it with some fatty food or with your KFC burger or something like that. And the second bit is that it comes into two formations. One is on the gelatin base, which is from the animal fat, and one is on the vegetarian or vegan base. So some people have preference, they would not like to go into animal gelatin. So some people are vegetarian, so that is also available on NHS. Thank you.
Yeah, so yeah, there is some that are not vegetarian, and there is a really useful resource, SPS, I'll put it in the chat later, which lists which ones are suitable for vegetarians and not. So that is an issue. You can use that resource, but I'll put that in the chat later, or I'll add it to the presentation, but very useful. Right, at number 6, it's a Omeprazole. So quite a few of you put PPIs in the chat. So it's a proton pump inhibitor that reduces acid and things like that. We use it commonly to treat lots of things. We use it in treatment, so preventing GORD happening, treating ulcers. We use it in H. pylori eradication. I'm laughing at the KFC prescribed. We also use it prevention. So if you're prescribing things like naproxen, ibuprofen for patients high on risk, we use it to protect the stomach. So it's stopping it eroding the stomach lining. So because of the stomach effects, of course, the common side effects are feeling sick, stomach ache, wind, tummy pain, being sick. Is generally in practice, I think it might be historically regarded as a pretty safe medicine, and I want to challenge that thought process. If they're on it to prevent because they're on higher risk medicines like naproxen and ibuprofen, like that, the benefits of being on it probably outweigh the risks. However, if they're on it for other causes, and they're on it long term, perhaps we should be indication dependent, be challenging that, because there's increased evidence that if you're on it for over a year, it increases your risk of bone fractures. It increases your risk of C. difficile, particularly if you've got a patient that's going into hospital where they're more likely to contract that. And there are links to electrolyte disturbances and things like that. So it's not as safe as the general perception, I think, in general practice is. So yeah, challenge that. So short course generally regarded as fine, but if you say prescribed it with ibuprofen or naproxen, has it been stopped when the naproxen ibuprofen has been stopped? So just making sure that you're checking on things like that. So this is a test yourself again. So I'll be using the chat, or you can stick your thumbs up. And Omeprazole is best taken on an empty stomach. PPI also with KFC.
Yes.
So is this true or false though? So
True.
it is true, yes. So the omeprazole full effects are seen after 1 to 2 days.
No.
No, actually, yeah, it takes a little bit longer. Can stopping smoking worsen acid reflux?
That's challenging. I think no.
No, the answer is no. So stopping smoking can make it better. So it's all the lifestyle measures can make the reflux better. So getting them to lose weight, exercise, things like that. And omeprazole should be co-prescribed with ibuprofen in patients greater than 65 years old.
I'm sorry, but this was my poster drug. So I've given a poster on Lansoprazole and PPI, so I know a bit about it. So it's a NOTS APC recommendation for any NSAID above 65. Chance of bleed is there, so we should give it. It's
Yes.
NOTS APC guidance.
Yeah, that's correct. So yeah, there's really good NOTS APC guidance of when we should be using it for protection. And I've actually, it's also got a list of the risks and things. So the link is there within the presentation, and there's also really good, useful de-prescribing advice, which is the link. Can long-term be associated with low vitamin D? I mean, can it cause, oh, good question. I don't know the answer to that. It has been linked with low sodium, low magnesium. And Mohammed, who's done a presentation, doesn't know. I can look into it. It can definitely cause electrolyte disturbances. And I've encountered low sodium and low magnesium, but I've not encountered vitamin D. So leave that one with me. Right, I'm conscious I've got 10 minutes. Oh, have you got a question there?
Yeah, if you're generally meant to take NSAIDs with food, if you're taking omeprazole as well, does it matter when you take your ibuprofen or naproxen as well?
I would normally recommend that they continue taking the non-steroidals with food and just taking the omeprazole before they have their meals. So not at the same time, but on the same day, if that makes sense.
Yeah, thank you.
Because we want to optimize the most. Maybe it weakens the bones. I'll have a look into that. Leave that one with me. I'm just conscious of time. So at number 5, and we've got to get to number 1. At number 5, we have levothyroxine. Again, this is one where timing is important. So it needs to be taken half an hour before the first meal of the day. It requires blood monitoring. So yeah, Brian, that's good. Blood monitoring, we normally have yearly bloods, or we check them at 3 monthly if the dose has been increased or decreased. If the dose is not right, that patient's weight might be changing. So if that patient's presenting with that, then that could be a reason to repeat the bloods. It's got some good interactions here. So iron tablets, calcium tablets, dietary supplements that might contain those products. So bear in mind that if they're on indigestion remedies as well. So we normally recommend that you separate the administration. The indigestion remedies, those are ones that contain like calcium and things like that, that they bind to the levothyroxine, reducing its absorption. And milk and cheese can always do so. It's all to do with, so high calcium foods can again delay, which is why we normally take, say, half an hour before the first meal of the day, so an empty stomach. So the BMF, which is the Pharmacist Bible, so to speak, recommend a 4-hour gap, but that information can change. There's some resources say 2 hours, but leave a good gap between any of those. I mean, the one we commonly encounter is levothyroxine in the morning, and then iron tablets should now be once a day. And so we would say to take with your main meal, so it separates them out in a good timing. Right, 4 and 3. I've combined these because they're both hypertension medicines. So we've got amlodipine, that's a calcium channel blocker. We commonly encounter this for hypertension and to prevent angina. So side effects, headaches, feeling flushed, and that's really common at the start. Swollen ankles is really common, particularly if they're on the higher dose. So they've got a 5 milligram dose and a 10 milligram dose, 10 milligrams, but you'll be looking for both ankles being swollen. So if you've got swelling in one ankle, then it's probably unlikely to be the amlodipine. But so if someone's newly started, or even quite a few months later, this could be a cause if they're presenting with a swollen ankles. If that patient has also been dizzy, could it be that we're overtreating the blood pressure? And that's relevant to all hypertensives. So you might want to do a blood pressure check, or if they're getting dizzy, are they getting postural hypertension? So do we need to do a sitting and lying or sitting and standing blood pressure check? So just bearing that in mind. Then a number 3 was Ramipril, which again is an angiotensin converting enzyme inhibitor. So it affects the pathway for blood pressure. Again, using cardiovascular disease and hypertension. Significant side effects, so dizziness when you first start. So that's postural hypertension when they first start. So we normally recommend the first dose at least is taken at night. So that if they're feeling dizzy, they're in bed and it's not an issue, but it normally resolves. If it continues, then we might need to change the medicine or things. The other side effect is a dry, irritating cough. And if that happens and it's irritating, then we normally would change that medicine. It's got a few serious but rare side effects, including allergic reactions. There's some hepatic impairment, pancreatitis. They're really rare, but just be aware. And it does require monitoring of renal function and potassium because it can cause high potassium. There's a link here to the Specialist Pharmacist Service resources. So that's where the vitamin D is. It also is under the sick man day rules, so the sad mans. And then, I don't know if anyone has come across this. So what is the evidence? So gpevidence.org is a website designed for primary care clinicians, and it lists all the commonly encountered long-term conditions, and it looks at the evidence. So if you've not come across this resource, I would recommend it. So should I use amlodipine or Ramipril? So of course, we generally follow NICE guidance in practice. However, what does the actual evidence say? What are the risks and benefits to the patient? And this resource is really good because you can use it to show the patient like what their risks are and then what the benefits are of taking those medicines. And you can also click on things like which drug. And actually, if you look into it, whilst NICE recommend a few differences, then there's no particular evidence really for doing one or more over the other in a standard patient. But yeah, they say follow NICE. But yeah, if someone comes in and they're not quite on the right medicine, but they're still on one of these, then I'd probably stick with it if they're doing okay and their blood pressure is under control. But yeah, Really, really useful resource. Right, we're getting towards the end. So number 2, lansoprazole. So we've kind of already covered the proton pump inhibitors. So it's very much like omeprazole. When do we use lansoprazole over omeprazole? Does anyone have an idea? I suspect Mohammed might.
I think it's the half-life and the compliance.
Yeah, there's some evidence that lansoprazole works better. However, in practice, it's if patients are on a medicine called clopidogrel, which is an antiplatelet.
Yes.
We use post-stroke or post-heart attack due to an interaction. So they realised that omeprazole reduced how well clopidogrel worked. So those patients are always generally on lansoprazole. And omeprazole, it's not so critical to be taken on a real empty stomach compared to lansoprazole. Lansoprazole, it says on the box, must be taken 30 minutes before meals. So we would generally use that. Right, so we're almost at the end. I'm just conscious of the time. So this is the top 10 recap. Those are the medicines that we've gone through. And at number 1, and some of you can get that gold star for getting it right, it is Atorvastatin. So I think prevention and lipid management are definitely higher on the agenda at the moment. And so statins are being very much prescribed both for primary prevention and for secondary prevention. And it reduces the cholesterol made in your body by blocking the action of the enzyme HMG-CoA reductase. Significant side effects that you might come across as muscle aches or pains, and we'll come across that, talk about that in a minute. But serious side effects you need that potentially to be aware of is lung disease, allergic reactions, and rhabdomyolysis. And that's kind of a spectrum of muscle pain, but that's the serious end. So I assumed a lot of you were physios. So could the reported muscle pain be statin related? So as a general rule, statins were found to be well tolerated and not cause muscle pain, and they actually found in trials there was a huge nocebo effect. So a lot of people reported muscle pains despite not being on statins. But in clinical practice, we find that that's not quite replicated. Up to 75% of people starting a statin will discontinue treatment within 2 years. We have some really, really good guidelines there. And there is a link here to the statin intolerance pathway. So if you've got someone with statin, newly started on a statin, particularly within the last 3 months, it might be that you want to refer to this pathway to rule out whether potentially the muscle pain they're experiencing is statin related. As a general rule, it's on both sides. So it's symmetrical pain and weakness in the large muscle groups. So if you've got pain on one side, then it's probably not statin related. But I don't have time to go through it, but this is a really useful flow chart that talks you through what to consider and what advice. And you can always signpost to the pharmacists who have a lot of training in this area. Brilliant. It's got a lot of interactions. I've not even covered them all, but if you're treating infections, Clostridium or paramedics, clarithromycin, some of the antifungals, colchicine if you're managing gout. The majority of the cases, because atorvastatin is a long-term medicine, you're talking about effects for the next 10 years. So if you have to stop it for a week or 2 whilst you give an acute course, that is fine as a general rule. If they're on a medicine long term, it might be you need to seek pharmacist advice about maybe reducing the dose if you come across any of the interactions that occur. But as a general rule, if something's short, just temporarily stop the statin and then get the patient to restart it when they've finished. And then the summary of today, because we're nearly at the end, you will commonly encounter these 11 medicines in practice, and hopefully you'll have a bit more of an increased awareness. It feels like a really whistle-stop tour. I thought I didn't have enough material, but actually I was totally wrong. And it's important that you have these awareness of where you'll encounter them and where to go. You're not expected to remember everything, just where to go. So if you encounter these, how can you ensure they're prescribed safely? How can you be involved in optimizing treatment? So do you signpost to the nurse or the pharmacist for an asthma review? And should you be stopping PPIs, for example, to go towards the NHS carbon zero target? You are definitely not alone in the management of these patients, so use your wider team to deliver the above agenda. So hopefully you found that useful and helpful. The slides will be sent out. There are loads and loads of links because I haven't had time to go through them all. I wish I had time to go through more of the contraindications and things like that. But hopefully, I wanted to make you aware of resources and things like that that might be useful in practice. So hopefully that's all been helpful. And we finished with 1 minute to go. So if anyone's got any quick questions or anything, and Mohammed, thank you for all your help and support and making it interactive and things.
It's really helpful. I would definitely put this in my portfolio. I've learned a lot. Thank you.
It's been absolutely fantastic, Sarah. Thank you so much. I think from all of the comments in the chat box, hopefully you can see how well received it's been. I'm sorry if we weren't quite as interactive. I think because so many of us come from a non-prescribing background, some of your questions we really had no idea of the answers. So I think it's not a reflection that people weren't really engaged. I think it was just a lack of knowledge.
No, brilliant. It was really hard to pitch because I was like, there's going to be some prescribers and non-prescribers. So this has been really useful for me. Right, we're going to go back, but thank you all for being a great audience.
Thank you, Sarah.